Our objectives for today are to briefly review thyroid physiology and the use of thyroid studies, to describe the diagnosis and treatment of hypo and hyperthyroidism in the pediatric age group, to appreciate the distinct features of these diseases in neonates, and to briefly review the management of thyroid nodules in children. I want to lay the background by briefly reviewing thyroid physiology and the appropriate use of thyroid studies. TRH, or thyrotropin-releasing hormone, is released from the hypothalamus and acts at the pituitary to increase the synthesis and secretion of TSH, or thyroid-stimulating hormone, which acts at the thyroid gland to cause the production, the synthesis and release of T4, which is thyroxine, and T3, which is triiodothyronine. And these then feed back at the hypothalamus and the pituitary to decrease the secretion of TRH and TSH, respectively. The thyroid is comprised primarily of thyroid follicles. These are lined with a single cell, and they have in the middle a colloid. And the colloid is primarily comprised of thyroglobulin, which is a large glycoprotein that has a bunch of tyrosine residues and basically acts as a scaffolding on which thyroid hormone is synthesized. This is a basic depiction of a thyroid follicular cell. Iodine enters the cell from the blood and goes into the follicular lumen through the pendrin channel, mutations in which cause pendrin syndrome. Once iodine is in the colloid space, DUOX and TPO act together to organify the iodide and make monoiodotyrosine, or MIT, and diiodotyrosine, or DIT. TPO further acts to combine two DITs to make T4, or thyroxine, on the surface of the thyroglobulin molecule, or to combine a DIT and an MIT to make T3. Most of this remains stored in the thyroid follicle, and when it's time for release, the thyroglobulin molecule is penocytosed and digested, and the T3 and T4 are released into the cell and then into the bloodstream. This is T4, and you can see the 4 iodine atoms on the molecule. T4 is the primary product of the thyroid gland, so it's secreted from the thyroid in about a 10-to-1 ratio as compared to T3. It is the predominant circulating thyroid hormone. It has a lower affinity than T3 for the thyroid hormone receptor, however, so T3 is really the primary acting thyroid hormone, whereas T4 is more like a precursor, although it does have some action. Most of T4 circulates bound to proteins. This is T3, which has 3 iodine atoms on the molecule. It's produced from T4 by types 1 and 2 deiodinase in different tissues in the body. About 80% of circulating T3 levels result from peripheral conversion of T4. And as we said, T3 has about a 10 to 15 times higher affinity for T4 than T4 at the thyroid hormone receptor. And a large percentage circulates bound to proteins. This is reverse T3, which is produced from T4 by type 3 deiodinase. Reverse T3 is inactive, but it's important to know about when we talk about non-thyroidal illness. To briefly compare T4 versus T3, the units of T4 are micrograms per deciliter as compared to nanograms per deciliter for T3, which emphasizes the fact that T4 circulates at a much higher concentration in the blood. As we said, T4 is much less potent than T3, which really can be considered the active hormone. The percent free is very low for both T4 and T3. The half-life of T4 is about 7 days, whereas the half-life of T3 is about 3/4 of a day. Most T3 and T4 are carried by thyroid binding globulin. The remainder is carried by transthyretin and albumin, and I just wanted to mention those once, but mostly we'll focus on thyroid binding globulin, or TBG, not to be confused with thyroglobulin that we talked about earlier. There are medications that increase and decrease TBG, and these are important to keep in mind. Estrogen in pregnancy can increase TBG. Glucocorticoids, androgens, and critical illness can decrease TBG. In addition, as shown here, there are some medications that alter the binding of T4 and T3 to thyroid binding globulin and can increase free T4 and free T3 concentrations. The final thing I want to remind us of in terms of thyroid physiology is the effect of iodine on thyroid function. There's 2 things that happen acutely when there's excess iodine exposure at the thyroid gland. First of all, iodine prevents the release of preformed T4 and T3. Second of all, iodine inhibits the organification of iodide, decreasing T3 and T4 biosynthesis, and this is known as the Wolff-Chaikoff effect. So the net effect of acute excess iodine exposure is typically hypothyroidism. There is escape from the Wolff-Chaikoff effect in a few weeks, however. This takes longer in infants and children than it does in adults. If someone has an underlying goiter from iodine deficiency or a multinodular goiter, then you may have actually a paradoxical acute effect of iodine to cause hyperthyroidism. This is much less common, but important to keep in mind. And finally, iodine does readily cross the placenta. So if there's excessive maternal iodine exposure after 10 weeks of gestational age, then the fetal thyroid will trap this iodine, and it may cause fetal goiter and hypothyroidism. So let's think about a case vignette. A 4-week-old term infant in the NICU has a TSH of 15, which is high, and a free T4 of 0.8, which is low for age. Previous thyroid screening was normal. The infant is also undergoing treatment for a large omphalocele. So what you would want to ask here, of course, is whether or not this infant has been exposed to iodine. And we get a lot of consults like this where hypothyroidism, especially mild hypothyroidism, is caused by iodine exposure. So the take-home point here is when you're evaluating new-onset hypothyroidism, it's important to consider iodine exposure through either skin preparations, this is especially relevant in NICU babies, radiographic contrast, or dietary supplements. Let's move on now to the different thyroid studies that we measure. TSH is the most commonly measured, and that's for good reason. The assay is pretty good, and TSH itself is very sensitive to small changes in circulating thyroid hormone. So it's often the first indication that hypothyroidism may be developing. Two important things to remember about TSH. First of all, it's increased in obesity and then normalizes if there's weight loss. And secondly, in hyperthyroidism, TSH is actually slower to reflect changes in thyroid status than T3 or T4, meaning that when someone's recovering from hyperthyroidism, you'll see the T3 and T4 decrease before you'll see the TSH increase. Total T4 and total T3 are actually pretty robust assays, but they're not sent very commonly because they're very sensitive to the amounts of thyroid binding globulin. I'm going to illustrate this with a figure, and the purple things are going to be the thyroid binding globulin, and the little pink circles are going to be thyroid hormone. So you see in the middle someone with normal amounts of thyroid binding globulin, and a measurement would show a normal T4, a normal total T4. And the free T4 you can see are these free pink circles, and the free T4 is 2. If you look on the left, this could be someone, say, with critical illness or someone who's had high-dose glucocorticoids, and the TBG is decreased. So if you do a total T4 measurement, you're going to actually get a low total T4. Whereas if you look at the free T4, these circulating, these pink circles, the free T4 is the same, or 2. Here you have somebody, say, who's pregnant or who's taking estrogen, and you have increased thyroid binding globulin. So you would have an increased total T4, whereas, again, the free T4 would be the same at 2. So to get around this problem of thyroid binding globulin, what we typically do is we measure free T4. Now, the gold standard for measurement is free T4 by equilibrium dialysis, but this is expensive and time-consuming, and it's typically not available for usual circumstances. So most of our labs provide free T4 estimations. Now, these may be so-called direct measurements of free T4, but they're not typically done with the gold standard, and they may not actually be reliable at extremes of thyroid binding globulin. And in addition, the assay is not quite as good as TSH assay. So if you have a TSH and a free T4 telling you different things, you typically want to rely on the TSH as the more sensitive and better assay. Older methods used index methods, either measuring total hormone and TBG to yield a free T4 index, or doing a T3 resin uptake to yield a free T4 index. Most of our labs don't do these anymore and just offer a free T4, but if your lab does do these, you can use the free T4 index the same way that you use the free T4. So in terms of what thyroid function tests are appropriate for which situations, for screening the thyroid, you want to definitely use a TSH, and in children especially, we tend to also add a free T4. In resource-limited settings, because primary hypothyroidism is much more common than secondary or tertiary hypothyroidism, you may want to just use a TSH initially. But if there's any suspicion for pituitary or hypothalamic disorder, then a TSH itself may be normal when you actually have hypothyroidism. So in kids, we tend to send both of these because a free T4 will pick up central hypothyroidism, whereas a TSH would not. For primary hypothyroidism, especially if you're monitoring treatment, a TSH may be enough. We do often send also a free T4. For secondary and tertiary hypothyroidism, the TSH is not going to be reliable, and we rely on the free T4 measurements, both to diagnose and to gauge treatment. And for hyperthyroidism, we send TSH, free T4, and total T3. The reason for this is because there's altered deiodinase function in hyperthyroidism, and often we can have what we call a T3 predominance, where the total T3 is relatively more elevated than the free T4 is. So we send all three of these. Total T4, as I said, is a robust assay, and it may actually be preferred in pregnancy, critical illness, or other situations where you really expect that you have maybe extremely low or high thyroid binding globulin. But otherwise, we tend to rely on the free T4. Free T3 is rarely used and really has limited utility. You probably won't find yourself sending this. And thyroglobulin is another test that's available, but is used primarily in the setting of either diagnosing or especially surveilling thyroid cancer. So again, this is not a test that we use very often. We often send thyroid antibodies because most of the thyroid disease that we deal with is autoimmune thyroid disease. So I wanted to go through these. The first and most commonly used is thyroid peroxidase antibody, and this has very high sensitivity for autoimmune thyroid disease. It's essentially always positive in Hashimoto's thyroiditis, and it also is sometimes positive in Graves' disease. Thyroglobulin antibodies serve somewhat the same function. There's some controversy about them because they may be negative in Graves' disease, and it's unclear if they add additional information beyond that provided by TPO antibodies. But we do often send both TPO and thyroglobulin antibodies when we're looking for autoimmune thyroid disease. When you're looking for Graves' disease in the setting of hyperthyroidism, the preferred tests are thyroid-stimulating immunoglobulins, and this is actually a bioassay where the patient's serum is tested to see the degree to which it stimulates the TSH receptor compared to controls. So labs report it differently. They may report either a 1 or a 100%, which would be normal. If the patient's serum stimulates 500 times the normal control, you might get a 5 or a 500% as your result. If you don't have TSIs available to you, you can send TSH receptor antibodies, also known as TSH receptor binding inhibitory immunoglobulins, or TBII. These measure both blocking and stimulating antibodies, so it's a little less clear because the balance of these may cause either hypo or hyperthyroidism. So really, TSI is the test of choice in Graves if it's available. We have two modalities of thyroid imaging that we use. The first is thyroid ultrasound, which is useful when you're investigating a palpable nodule or when you're surveilling someone who's had a history of thyroid cancer or a history of radiation therapy to the thyroid area. It also may be useful in neonates with hypothyroidism. The second modality that we commonly use is thyroid scintigraphy, or what I'll refer to as an uptake scan. We use either 123 iodine, which is mildly radioactive, or technetium-99, and both of these are basically radioactive scans. And these are taken up when the thyroid gland has avidity for iodine. So these are useful to assess thyroid nodule function in the context of hyperthyroidism when you think you may have an autonomous nodule, or they're useful, as I'll talk about in a minute, to distinguish between Graves' disease versus destructive forms of hyperthyroidism. So let's look at another case vignette. A 14-year-old girl presents with a 10-pound weight gain over the past year. Her growth and pubertal development are normal, and her review of systems is negative, except that she feels tired often. Her mother has hypothyroidism requiring treatment. Her height is 90th percentile for age, and her weight is 99th percentile, such that her BMI is 99th percentile. So you send thyroid studies, and you get a free T4 of 1.3, which is normal, and a TSH of 5.9, which is slightly high. Now, especially given the mother's history, I would send thyroid antibodies as the next step in this case. And so you see that anti-TPO antibodies are normal, and anti-thyroglobulin antibodies are also negative. So the most likely answer in this case is obesity. And the take-home point here is that mild elevations in TSH between about 5 to 10 are pretty common in obesity, and these are reversible with normalization of weight. They don't require treatment if the free T4 is normal and the antibodies are negative. Let's look at another vignette. So a 6-year-old boy is in the ICU following an accident in which he was struck by a car. He's intubated and sedated. A large number of labs, including thyroid studies, are sent, and the results are as follows, with a slightly low TSH, a slightly low total T4, and a free T4 that's just at the lower edge of the normal range. So this boy in the ICU, intubated and sedated, likely has non-thyroidal illness or euthyroid 6 syndrome. So what happens in fasting and critical illness is that there's a significant decrease in thyroid binding globulin. And in addition, there's an alteration of deiodinase function. So the first thing that happens is there's a decrease in function of type 1 deiodinase such that T4 to T3 conversion is less, decreasing your T3. And secondly, there's an increase in function of type 3 deiodinase such that more T4 is metabolized to reverse T3, decreasing the total amount of T4 and increasing the total amount of reverse T3. And the degree of this depends on the severity or the degree of severity of the illness. So in mild illness, you would see a low total T3 and a high reverse T3, but your free T4 and your TSH would likely remain normal. In moderate illness, you'll see a more significant decrease in total T3, and you'll see potentially a decrease in TSH. Reverse T3, as expected, will be high, and free T4 can either be normal or low because of the decrease in total T4, or it can actually be transiently high because of the significant reductions in thyroid globulin and thyroid binding globulin. In severe disease, you'll see a significant decrease in total T3, a decrease in free T4, an increase in reverse T3, and a decrease in TSH. And it's also important to keep in mind that during recovery from non-thyroidal illness, the TSH may be transiently elevated. Another important thing to consider in this case vignette are drugs that affect thyroid function. In the ICU setting, both opiates and dopamine and dobutamine decrease TSH, so it's important to keep that in mind. In addition, high-dose glucocorticoids can decrease TSH, as can octreotide. Many of the anti-epileptic medications can increase the metabolism of T3 and T4, and there are also medications that inhibit the conversion of T4 to T3. Two primary medications that I wanted to mention especially that often affect thyroid function are first amiodarone, which typically causes hyperthyroidism secondary to thyroiditis and iodine loading, and secondly, lithium. The usual effects of lithium are goiter, possibly autoimmune thyroiditis, and hypothyroidism. In rare cases, though, lithium can also cause hyperthyroidism. So the take-home points from this vignette are that you should only check thyroid studies during a significant illness if there's a clear clinical reason. Otherwise, you may get abnormalities in thyroid functions that you're not quite sure what to do with. So if possible, thyroid tests should be deferred until the resolution of illness. And TSH may be mildly elevated during resolution. The second take-home point is whenever you're looking at perturbations in thyroid function, look at the patient's other medications, as many medications interfere with thyroid function. And finally, it's not currently standard of care to treat non-thyroidal illness. There's some controversy about whether or not this is an adaptive state, but currently we do not treat. So let's move on to describe the diagnosis and treatment of hypothyroidism in the pediatric age group. The signs and symptoms of hypothyroidism in children are probably familiar to you. To me, one of the more important symptoms is decreased growth velocity, as you can see in this growth chart. In addition, commonly you'll see thyroid enlargement or goiter. You may see constipation, sluggishness or decrease in energy, cold intolerance, dry skin or brittle hair, sometimes with hair loss. And children who've already had menarche may have irregular menses. Hypothyroidism can also cause pubertal delay, and much less commonly it can cause pubertal precocity. And finally, there may be a change in behavior or school performance. Notably absent from this list is weight gain. Although hypothyroidism does decrease metabolism, significant weight gain is not a common presenting symptom of hypothyroidism. And often when we treat hypothyroidism, we do not see significant weight loss. This doesn't mean that I don't screen patients with obesity for thyroid disease, but honestly, this is probably somewhat of a waste of resources, as it's very uncommon to see significant weight gain as a presentation of hypothyroidism. In terms of physical exam and lab abnormalities that you may see reduced heart rate and decreased myocardial contractility. A good physical exam sign is delayed relaxation phase of the deep tendon reflexes. You may see dry skin, often periorbital puffiness and significant hypothyroidism and some non-pitting edema. And in terms of lab abnormalities, hypercholesterolemia and hyponatremia are associated with hypothyroidism, as is anemia. And in extreme cases, you may see elevated CK, elevated LDH, and elevated transaminases. The most common cause of hypothyroidism is primary, or a problem with the thyroid gland itself. And the most common cause of primary hypothyroidism is Hashimoto's thyroiditis. In addition, children who've had irradiation to the neck area, particularly because of cancer treatment, may develop primary hypothyroidism. Iodine deficiency is the most common cause worldwide, but is not seen commonly in the United States. Infiltrative diseases or drugs may cause hypothyroidism. Trisomy 21 is associated with a higher risk of hypothyroidism, as we'll discuss, and of course congenital hypothyroidism, which I'll discuss separately. Secondary hypothyroidism is less common and is caused most likely by hypopituitarism. In addition, any children who has a CNS lesion or injury or has been treated for such with cranial irradiation may develop secondary hypothyroidism due to pituitary dysfunction. If children receive more than 10 grays of radiation to the pituitary, it's possible that they'll develop thyroid dysfunction due to decreased TSH synthesis. If they receive more than 50 grays, it's nearly certain that they'll develop secondary hypothyroidism. Another important cause to keep in mind is hemangioma in young infants, and this is actually a consumptive hypothyroidism that requires really aggressive treatment. This is not common, but important to keep on your differential for severe hypothyroidism in infants. And also, while not a cause of real hypothyroidism, it's important to remember lab abnormalities and to always confirm your thyroid tests at least one additional time. In terms of testing for hypothyroidism, in children, I typically send a TSH and a free T4. And of course, if both of these are normal, you're finished and don't need any further testing. If the TSH is normal or low and the free T4 is low, then you're in a situation where the TSH is inappropriate for the degree of free T4 and you have possible central hypothyroidism. You would want to confirm this with additional labs, and if it is confirmed, this requires an endocrine referral because there may be other pituitary deficits that need to be investigated. If the TSH is high, but the free T4, the circulating thyroid hormone, is normal, then you have a situation of subclinical hypothyroidism. You also would want to repeat your tests, and you would want to send antibodies to see if this is due potentially to a Hashimoto's thyroiditis. And we'll talk about the treatment in just a minute. If the free T4 is low and the TSH is high, then you have frank or overt hypothyroidism. You would, again, want to repeat the tests always at least one time to confirm, and also send antibodies to look at the etiology, but you would want to start treatment in this case. So let's look at a case vignette. A 10-year-old boy with long-standing type 1 diabetes presents for his annual physical. He's only grown 2 centimeters in the past year, and his height has decreased from 50th to 30th percentile. His thyroid studies were last checked 2 years ago and were normal. You can probably guess where I'm going here, and of course you'd want to check thyroid studies in this child. And thyroid studies show a TSH of 40, which is high, a free T4 of 0.7, which is frankly low, and positive TPO antibodies of 112. So this child has Hashimoto's thyroiditis. And that brings us to the take-home point that there are groups of individuals who have higher risk for Hashimoto's thyroiditis and in whom you should check thyroid studies annually. So these include people with type 1 diabetes, celiac disease, trisomy 21 or Down syndrome, and Turner syndrome. In addition, in infancy, both children with trisomy 21 and children with Williams syndrome may have a subclinical hypothyroidism, and it's important to check thyroid studies in these individuals as well. Hashimoto's thyroiditis is by far the most common cause of both subclinical and overt hypothyroidism. This is also known as autoimmune thyroiditis or chronic lymphocytic thyroiditis, all different names for the same thing. You often, but not always, will see a goiter in Hashimoto's thyroiditis, and the goiter is due to lymphocytic infiltrate. It's not necessarily due to overactivity of the thyroid gland, so treating the hypothyroidism does not always reduce the goiter. Actually, it typically doesn't. And the goiter is generally painless, which is important to keep in mind. The presence of thyroid antibodies, anti-TPO and or anti-thyroglobulin, essentially is enough to establish the diagnosis. And you want to do ultrasound only if you feel a palpable nodule. There will be small abnormalities on ultrasound in a lot of these patients, so you don't want to do ultrasound unless there's a palpable nodule that you're worried about. The course of Hashimoto's thyroiditis is waxing and waning. Somebody with subclinical hypothyroidism may stay that way for several years. However, the general trend is a loss of thyroid function over time. And in studies of adults who have positive antibodies but have either normal thyroid function or subclinical hypothyroidism, overt hypothyroidism occurs at a rate of about 5% annually. In addition, as we'll talk about a little more later, as I said, there's a lot of thyroid hormones stored in the thyroid follicles. So thyroid destruction from Hashimoto's thyroiditis can result in release of thyroxine, which can cause hashitoxicosis, which is a transient phase of hyperthyroidism, particularly in the early phases of the disease. In terms of treatment, if you have subclinical hypothyroidism, the treatment is somewhat controversial. Most of us agree that if the TSH is above 10, you do want to go ahead and start treatment. The thinking being that it's a relatively significant elevation and it's probably not going to return to normal. However, if the TSH is between 5 and 10, it's much more of a gray area, and I typically discuss the pros and cons of treatment with the family, and their decision is very important in terms of my decision for treatment or not. Levothyroxine is very safe, so I do often err on the side of treatment in a few circumstances. First of all, if the age is less than 3, there's significant neurodevelopment going on for which thyroid hormone may be very important, so I do often err on the side of treatment. In addition, if someone has positive antibodies confirming Hashimoto's thyroiditis, you may want to go ahead and treat with the thought that the likely course is that this will get worse. If there are symptoms such as decreased energy or weight gain, these may or may not be caused by the hypothyroidism. The actual circulating level of free T4 is normal. Sometimes patients report improvement in these symptoms with treatment, so I do sometimes treat just to see either if the symptoms will improve, or if not, we can take hypothyroidism off the table as a cause for the symptoms. And finally, especially in younger children, if there are concerns about growth or development, I do typically tend to err on the side of treatment. If the TSH is less than 10 and one decides not to treat, it's very important to monitor thyroid studies about annually or sooner if there are symptoms to make sure that you're not missing a further elevation in TSH, which you should treat. In terms of the treatment for overt hypothyroidism, there's no controversy here. Levothyroxine is most certainly the recommended treatment. And I did want to particularly mention, we don't recommend Armour thyroid because we're not sure about the concentrations in the preparation. And we don't recommend Cytomel, which is essentially T3 treatment. Cytomel has a much lower half-life, making the concentrations, if you treat, much more kind of up and down. And finally, there's a lot of physiologic regulation with the deiodinases. In other words, the peripheral conversion of T4 to T3 is actually pretty closely regulated. So if you give Cytomel, you're taking away this physiologic regulation. So the American Thyroid Association recently came out and reconfirmed that levothyroxine is most certainly the recommended treatment, and we don't use these other two. You may need Cytomel in the case of consumptive hypothyroidism because of a hemangioma, but that's the only circumstance in which we use it. The dosing of levothyroxine is weight-based, and you can see that it's also age-dependent. And obviously, those with mild hypothyroidism will need less levothyroxine than those with severe hypothyroidism. And then we titrate the dosing in order or by labs. We use generic or brand levothyroxine. There have been conflicting studies on this, but essentially the bioavailability is pretty similar. And we always use levothyroxine tablets. You can get liquid preparations from compounding pharmacies, but we don't necessarily trust the concentrations in these. So we always use tablets, and these can be crushed for infants or small children. Just a couple things to know about levothyroxine. It has a pretty long half-life, similar to T4 of about a week. And so it does take about 4 to 6 weeks to see an effect on TSH when you either start or change your dose. And because it has such a long half-life, a missed dose can be easily handled by just doubling the dose the next day. Levothyroxine absorption is decreased by soy, iron, and calcium. So it's important to keep this in mind and not co-administer these things. The absorption is really best if it's taken on an empty stomach, but we don't necessarily require our patients to do this. We ask them just to be consistent with administration. So if they take it with meals, because that's the most convenient, that's fine as long as they consistently take it with meals, and we can increase the dosage if necessary. Levothyroxine is a great drug in the sense that the only side effects are those caused by giving too much of it, i.e. hyperthyroidism, and otherwise it doesn't have any side effects unrelated to its mechanism of action. And I just want to mention once that in pregnancy, dose increases of levothyroxine are needed. So if you have any adolescent patients who become pregnant and they're on levothyroxine, it's very important that these patients see a thyroid specialist or an OB familiar with this, because they will need increases during pregnancy. Once you initiate treatment in overt hyperthyroidism, the goal is, overt hypothyroidism, the goal is generally to keep the TSH between about 0.5 and 2.5, or in the lower half of the normal range. And so we titrate our dose to achieve this goal. In terms of lab frequency, we send labs monthly during infancy, and then, as shown here, slowly space out, such that by the time someone's completed growth, annual labs are typically enough. And then once you change dose or when you start thyroid treatment, we check the labs 4 to 6 weeks later, as I mentioned. So let's move on to the diagnosis and treatment of hyperthyroidism in the pediatric age group. The signs and symptoms of hyperthyroidism typically start with goiter. And if you listen with a stethoscope on the goiter, you often hear a bruit because of increased vascularity. In addition, children may have increased growth velocity and advancing bone age. They may have weight loss in spite of hyperphagia. They often have sinus tachycardia, increased systolic blood pressure, and they may present with a gallop. They have diaphoresis, tremors, tongue fasciculations, and often this is not a subtle presentation. The child will sit in your exam room and literally appear as if they're jumping out of their skin. Children may have diarrhea, they may have a thyroid stare or a lid lag, and if they have Graves' disease, they may have ophthalmopathy with exophthalmos, although this is less common in children than it is in adults. Children who've had menarche may have irregular menses, and paradoxically, some people with hyperthyroidism have pretty significant fatigue. Graves' disease is by far the most common cause of hyperthyroidism, and it's caused by TSH receptor stimulating antibodies. So in other words, antibodies that sit at the TSH receptor and cause it to act. As Hashimoto's, it's much more common in females than in males, and we typically see Graves' in the adolescent age group, although it certainly can occur earlier. Again, as with Hashimoto's, there's an increased incidence in trisomy 21 and in Turner syndrome. Graves' disease can have with it ophthalmopathy, although this is less common in children than in adults. And if this is present, referral to an ophthalmologist should be made. TSIs, if positive, are enough to confirm the diagnosis of Graves' disease. If TSIs are normal, or if you're relying on TBII, then we also typically obtain an uptake scan. And there will be, in Graves' disease, increased uptake on a technetium or an iodine 123 scan. And that's because the thyroid is avid to take up iodine. For treatment of Graves' disease, the initial treatment is usually twofold. First of all, we usually use a beta blocker to manage the heart rate and the blood pressure. And secondly, we typically start methimazole. You can move quickly to more definitive treatments such as radioactive iodine or surgery, but we typically start with methimazole because a small percentage of patients do have remission of Graves' disease, and we often want to give patients a chance to have remission if they will. Methimazole is associated with decreased neutrophil count as well as increased transaminases. So you want to monitor ANC, ALT, and AST during treatment. And then you wean your methimazole as possible over 1 to 2 years. And some patients will be able to stop methimazole, although this is not common. Remission occurs in less than half of patients. If patients require long-term treatment for Graves' disease, in other words, if they don't remit, you can continue treatment with methimazole, but many times patients opt for a more definitive treatment. So you can either use radioactive iodine, which is 131 iodine that's given orally and then taken up by the thyroid gland and destroys the thyroid gland over the course of several weeks due to the radioactivity. This typically can be done in children over 5, and we don't usually do it in younger children. Younger children or children with other circumstances can have a thyroidectomy instead, but you do need a very experienced surgeon to do this because of the other important structures in the neck. Hashitoxicosis is another cause of hyperthyroidism. It's less common than Graves' disease, but we do see it relatively frequently. And again, this is the destructive phase of Hashimoto's thyroiditis, where the thyroid follicles are being destroyed and the preformed T4 and T3 are being released. This phase typically lasts a few weeks to a few months. And again, you can diagnose it with antibodies. The TPO and the thyroglobulin will typically be positive. The TBII may be positive or negative. That's the measurement of antibodies that may be either blocking or stimulating at the TSH receptor. And the TSI, which is the thyroid stimulating immunoglobulins, will be negative. An uptake scan would show decreased uptake because you're in a destructive process rather than having an avid thyroid as you do in Graves' disease. The treatment is supportive. We use beta blockers, typically atenolol for tachycardia or hypertension if needed. And then we closely monitor because this typically will evolve to hypothyroidism. Subacute thyroiditis is another important cause of hyperthyroidism to keep in mind. And this typically follows a viral infection. The hallmark is a very painful or tender thyroid. And in addition to this, individuals may have fever, malaise, myalgia, decreased appetite. And there are typically a few phases of subacute thyroiditis. In the initial phase, because thyroid tissue is being destroyed, like in hashitoxicosis, you have release of preformed thyroid hormone, so you're hyperthyroid for typically 2 to 8 weeks. Then there's a transient euthyroid phase. This is followed by a hypothyroid phase because there's been destruction of the thyroid. You don't, however, have persistent autoantibodies, so then there's typically recovery, such that someone with a subacute thyroiditis typically evolves to persistently normal thyroid function over the course of a few months. In terms of labs, in addition to your abnormal thyroid studies, you may see leukocytosis and increased ESR and CRP. And imaging, like in hashitoxicosis, will show decreased uptake. Imaging is not necessary if the diagnosis is otherwise clear. In other words, there's a good history of preceding viral illness, a very tender thyroid. The treatment, again, is supportive. So we use beta blockers, often atenolol for tachycardia or hypertension. And you can use NSAIDs or glucocorticoids to help with the significant pain that individuals sometimes have. So these three are really your most common causes of hyperthyroidism, and I just wanted to contrast them quickly. So in terms of exam, you're going to see a goiter most commonly in all of these situations. In Graves' disease, there may be a bruit when you listen over the goiter, which would not be present in the other two. That's because there's increased vascularity in Graves' disease, whereas the other two are destructive processes. And in subacute thyroiditis, the goiter is typically tender, whereas it's not in Hashimoto's or Graves' disease. In terms of the actual thyroid studies, they don't typically help much. You may have a T3 predominance in Graves' disease, but this is not enough to reliably make the diagnosis. And often in Hashimoto's or subacute thyroiditis, your elevations in T4 and T3 will be milder, but again, you can't rely on this. It's not always the case. In terms of antibodies, positive TSIs are diagnostic of Graves' disease and won't be present in the other two conditions. And in subacute thyroiditis, you usually have negative antibodies. Because there's some prevalence of weak antibody positivity in the general population, you may also see weakly positive antibodies, but this is not related to the process of subacute thyroiditis itself. And if you do an uptake scan, again, you'll see increased uptake with Graves and decreased uptake with the other two conditions. So I want to go over a case vignette. So this compares two patients who had pretty similar thyroid studies, as you can see here. And the next step, of course, was to measure antibodies. So patient number 1 had negative TPO antibodies, speaking probably against Graves' disease. There were weakly positive thyroglobulin antibodies, and TSIs were normal. Patient 2 had elevated TPO antibodies and significantly elevated TSIs. So this really speaks very much toward Graves' disease. We went on to get thyroid uptake scans in these patients, and you can see that patient 2 had a very avid thyroid, confirming the diagnosis of Graves' disease, whereas patient number 1 has essentially no uptake. It's very difficult to see. You can see a little bit potentially of uptake here, but it's decreased compared to normal. So patient number 1 also had a tender thyroid, which was a tip-off for subacute thyroiditis, in addition to the negative TPO antibodies. So patient number 1 had evolution and resolution of hyperthyroidism over the course of a few months, whereas patient number 2 required treatment for Graves' disease. I just want to very briefly mention a few less common causes of hyperthyroidism. So acute suppurative thyroiditis caused by an acute infectious process can cause hyperthyroidism, although most commonly these patients are euthyroid. This also will present with fever and an infectious presentation, as well as painful thyroid. You can have an autonomously functioning nodule in the thyroid gland, and typically this will be palpable and show increased uptake on an uptake scan, whereas the rest of the thyroid tissue will be suppressed. Multinodular goiter is another cause, and again is evident on exam. McCune-Albright can also cause hyperthyroidism. You want to keep in mind factitious hyperthyroidism, in other words, say an adolescent trying to lose weight taking her mom's thyroid pills. And as we mentioned before, there can be iodine-induced hyperthyroidism in the case of iodine deficiency or multinodular goiter. TSH-secreting adenomas do exist, but they're incredibly rare. And you can also have pituitary resistance to thyroid hormone, where essentially you lack the feedback of T3 at the pituitary such that you increase TSH and end up in a hyperthyroid state. This too is incredibly rare. And all of the above causes will have negative antibodies, or because of the prevalence in the general population, weakly positive antibodies. Subclinical hyperthyroidism exists just as subclinical hypothyroidism does. This would be a TSH between about 0.1 to 0.5 with a normal free T4 and a normal total T3. And the usual course of this is resolution, although it could be a mild form of Graves' disease. So we do follow these people serially, but we typically don't treat them. Levothyroxine is a pretty safe medication, so we often do treat subclinical hypothyroidism. In contrast, methimazole does have some relatively significant side effects, so we tend not to treat in this case. So let's move on to neonates. So in terms of fetal thyroid function, maternal T4 is pretty important during the first 20 weeks of gestation. There are deiodinases in the placenta, so not all of maternal T4 crosses into the fetal circulation, but some does and appears to be important. Starting at about 10 to 12 weeks gestation, embryogenesis of the thyroid is complete, and the thyroid gland does start trapping iodine and synthesizing T3 and T4 production. This is at pretty low levels until about 18 to 20 weeks gestational age, when you have some hypothalamic pituitary thyroid axis maturation, and you see relatively significant increases in the T3 and T4 production. Importantly, the hypothalamic pituitary thyroid axis maturation occurs through gestation, and the maturation increases as you progress in gestational age. At birth, the cold stimulus produces a significant surge in TSH, and this causes increased T3 and T4 as well. So to look at this a little more closely, all labs are different. These are the lab norms for endocrine sciences, and labs will have different norms. But just to look, you have a peak of TSH at about 30 minutes. This is typically between about 60 to 80, but can range from about 25 to 160. And this goes down slowly, such that between about 3 to 5 days of life, you can have a normal TSH up to 16. And in the first year of life, you can have a normal TSH up to about 7. The total T4, because of the TSH surge, increases significantly and is high around 3 to 5 days of life and decreases during the first year and then decreases further after that. And you see a very similar picture for the total T3 here. So again, your own lab should have its own specific norms. And another thing to keep in mind if you are working with a primarily adult lab, just make sure that the norms that you're getting are for children, or look up a separate source for pediatric norms in case you're getting adult norms. So there's special circumstances of thyroid function in the preterm infant. As we said, the hypothalamic pituitary thyroid axis continues to mature throughout gestation, and serum T4 increases steadily with gestational age. So it's very often the case that preterm infants have a reduced TSH surge, and it's common for preterm infants to have decreased total and free T4 with a normal TSH. This often will correct spontaneously if you follow it over several weeks. And we don't typically treat these infants. There's not good data to show that treatment is beneficial. Low birth weight infants, if infants less than 1,500 grams birth weight, may have an atypical hypothyroidism with a delayed TSH rise. So most NICUs have protocols in place where they repeat the newborn screen about every 2 weeks. And it's very common to see a TSH rise at the second scan, or sorry, the second newborn screen, which you didn't see at the first newborn screen. And this may represent a real hypothyroidism that you need to treat. And finally, prematurity itself is associated with an increased risk of both transient and permanent congenital hypothyroidism. The course is pretty difficult to predict, so these children should be treated and followed. And then once the child is 3 and most of the myelination of the central nervous system is complete, for children who you suspect have had a transient or very mild course, you may want to do a trial off of therapy. The epidemiology of congenital hypothyroidism is that there's increasing prevalence now that we're doing newborn screening. So the estimation in the United States is about 1 to 2,000 to 1 to 2,500, although some studies show an even higher prevalence. The incidence in countries before newborn screening was more in the order of 1 to 4,000 to 1 to 6,000. So probably we're catching some mild cases that may not have been caught before. And the incidence does vary by ethnicity or race. Congenital hypothyroidism is the most common congenital endocrine disorder, and it's a very common cause of preventable developmental delay. So newborn screen has been really critical in catching this and preventing cognitive delay in these infants. In terms of etiology, about 80 to 85% of cases of congenital hypothyroidism are caused by abnormal development of the thyroid gland. So either thyroid agenesis or dysgenesis or an ectopic thyroid. And these are generally caused by sporadic mutations. About 15% are caused by dyshormonogenesis. Typically, this is autosomal recessive and a defect in any of the proteins that I showed you that are responsible for getting iodine into the gland, organifying it, making T3 or T4, and then releasing T3 or T4. So if you have a family history and an infant who you think has dyshormonogenesis, it's important to do genetic screening so that you can identify the cause of this for genetic counseling for the rest of the family. It's also important to remember that maternal administration of iodine can cause iatrogenic congenital hypothyroidism. And in addition, if the mother has TBIIs, or antibodies that sit at the TSH receptor and block its action, then these can pass to the fetus and may cause transient hypothyroidism in the young infant. Finally, there can be secondary or tertiary congenital hypothyroidism. This is less common and is commonly due to congenital hypopituitarism. The signs and symptoms to keep in mind for a neonatal hypothyroidism are prolonged jaundice, feeding difficulty, hypotonia, macroglossia, umbilical hernia, decreased growth, developmental delay, enlarged fontanelles or increased cranial sutures, or the persistence of a posterior fontanelle. In terms of newborn screening, most newborn screening programs are either TSH-based or primarily T4-based with a reflex TSH for those infants with low total T4. And normal results on a newborn screen shouldn't preclude subsequent testing if you really suspect that an infant has thyroid disease. So if you get an abnormal newborn screen, the important thing to do first is to confirm that the newborn screen was sent after 24 hours of life. In the first 24 hours of life, you have that TSH surge, which may cause a false positive. And in addition, you want to think about the gestational age and birth weight of the infant. If it's a preterm infant or the value was drawn before 24 hours of life, you probably want to repeat the newborn screen. And in addition, the rest of the protocol that I'm going to show you may not be applicable. So you want to be in close contact with your endocrinologist and with the newborn screening staff. If the test was sent after the first 24 hours of life and you have a term infant, if the TSH is greater than 40, then you absolutely want to start treatment as soon as possible. You do send TSH and free T4 prior to the initiation of treatment, but you don't wait for the results in order to start treatment. And you may want to consider a technetium scan or a thyroid ultrasound to see if the thyroid is normally located or potentially ectopically located. You may have no thyroid gland, which would speak to a problem with thyroid agenesis, or if you have a normally located thyroid gland, it's probably dyshormonogenesis. If the TSH is less than 40 but is abnormal, then you do want to also send a TSH and a free T4, but presuming that you can get these results back in a pretty timely manner, you can wait for the test results before treating. If your repeat TSH and free T4 are normal, then you probably had a false positive screen. If your repeat TSH is greater than 20 and or your free T4 is frankly low, then you do want to start treatment right away. You may want to consider measuring TBIIs in the mother because this may show an etiology, and you may also want to consider technetium scan or ultrasound. If the TSH is high but it's less than 20, this is a little bit more of a gray area. You may start treatment or you may elect to just observe the neonate and repeat tests in 2 weeks. I often would start treatment if, say, the TSH was 19, but if the TSH is 9, we often would observe and repeat the testing in 2 weeks. If you do decide to just repeat the testing without treatment, it's really important to follow it up and make sure that you see a normalization in TSH. If TSH is persistently elevated through the first month of life, you probably do want to start treatment. In terms of treatment for congenital hypothyroidism, we use levothyroxine tablets, and we crush these up and give them in a bottle nipple mixed with a non-soy formula or breast milk. And this is a little bit controversial. Some people recommend using brand levothyroxine. We use generic or brand and try to avoid switching preparations just such that we can titrate the dose accordingly. We start with 10 to 15 micrograms per kilo per day, and during the first 3 days, we tend to round up, meaning that in a normal-sized term infant, we would typically start with 50 micrograms for 3 days and then decrease down to 37.5 micrograms. And the purpose of this is really to normalize the total and free T4 as soon as possible. You want to recheck the free T4 in 1 to 2 weeks, and then you want to also check the TSH every 2 weeks until it normalizes. Once your TSH has normalized, we check monthly labs every month until 1 year of age. And if there's mild hypothyroidism or no dose increase of levothyroxine is needed, again, you may want to consider a trial off therapy at the age of 3 years to see if it was transient. A take-home point here, which I've already said but want to re-emphasize, is that liquid preparations of levothyroxine really should not be given because concentrations may be highly variable. So we really do want to use the crushed up tablets and not use the liquid preparations. In terms of outcome of congenital hypothyroidism, prior to newborn screening and rapid treatment, this really could be a relatively devastating condition with neurodevelopmental impairment, significant reductions in IQ, as well as decreased motor skills and decreased visual processing. Hearing loss was common, as were behavioral problems. Now, in infants who are diagnosed by newborn screen and treated with the standard of care, such that T4 is normalized pretty rapidly, there's typically the same intellectual and developmental outcomes as in the general population. However, if it takes longer to normalize the free T4, one study did report worse motor and balance outcomes. And even treated infants may have some hearing loss. This is associated with the severity of hypothyroidism at birth. So children with congenital hypothyroidism should have hearing tests. To switch gears and talk briefly about neonatal hyperthyroidism, this is nearly always the result of maternal Graves' disease and is caused by maternal TSH receptor activating antibodies crossing the placenta. It happens in about 1 to 5% of mothers with Graves, and it's much more common in women who have very active Graves' disease. It can also happen, though, if women have had Graves and they've had a thyroidectomy or radioactive iodine, but they still have antibodies circulating. The greatest risk for neonatal Graves' disease is if the maternal TSIs are greater than 5 or greater than 500%. And these infants should be followed carefully, even prenatally. So you may see on a 20-week ultrasound a fetal goiter with increased vascularity and tachycardia. Now, if a mom is being treated with antithyroid drugs, a fetal goiter on ultrasound may also be due to hypothyroidism, but you wouldn't see the tachycardia or the increased vascularity. And another important thing to keep in mind, if the mom is taking antithyroid drugs, these do cross the placenta, and so the infant may be hypothyroid or euthyroid or hyperthyroid at birth. And once these, the medication concentrations decline in the infant's system, typically hyperthyroidism may develop in 7 to 10 days. The clinical features of neonatal hyperthyroidism include goiter, tachycardia, as I mentioned. Many of these infants are IUGR and have poor postnatal weight gain as well. Some of these infants may be premature, and they often, again, don't have a very subtle presentation. So they'll be very irritable and jittery and not sleep well. They can have warm, moist skin. Craniosynostosis can occur, or microcephaly with frontal bossing and triangular facies. And infants, too, can have a thyroid stare, and in severe cases can have hepatosplenomegaly. So in terms of screening an infant, if you know the mother has Graves' disease, first of all, it's very helpful if you can measure the maternal TSIs during the 3rd trimester, because this gives you a sense of the infant's risk for having neonatal Graves. And infants born to moms with Graves' disease should have TSH and free T4 checked soon after delivery, keeping in mind the normal values. But if there's significant Graves, the TSH will be significantly suppressed. And again, that's not subtle compared to the usual presentation of thyroid tests. And if these are normal, especially on a mom, especially an infant of a mom who's received thyroid drugs, you probably want to recheck at 1 to 2 weeks of life once the concentrations of these drugs are out of the infant's system. In terms of treatment, we use a beta blocker, again, to control hypertension and tachycardia. And you can use either methimazole or iodine. SSKI stands for supersaturated potassium iodine, and either of these typically works quite nicely. We do weekly labs and then wean these medications as tolerated. And typically, as the antibodies clear from the infant's system, there's resolution by about 20 weeks, often earlier. So I want to just very briefly review the management of thyroid nodules in children. The main thing to keep in mind is that thyroid nodules in children have a higher risk of malignancy than in adults, and so any palpable nodule requires workup. And the first step in workup is to send a TSH and a free T4. And if the child is euthyroid or hypothyroid, then you want to proceed to a thyroid ultrasound. If the thyroid ultrasound shows that the nodule is greater than 1 centimeter, or if it has any suspicious features such as calcifications or heterogeneity, you want to proceed to a fine needle aspiration, which will be done by a thyroidologist. If the nodule is less than 1 centimeter and there are no suspicious features, then this can be followed by serial ultrasound. We typically do these yearly for a few years, and then if there's minimal change, we can space out the ultrasounds. If the child's hyperthyroid, then you're much more likely to suspect a hot nodule, and so the first step is an uptake scan. If the uptake scan shows a, quote, cold nodule, in other words, the nodule is not taking up iodine or technetium, then you move back to the thyroid ultrasound pathway. If you do have a so-called hot nodule, meaning an autonomously functioning nodule that takes up technetium or iodine, then these are very, very rarely malignant. So you can treat the hyperthyroidism if necessary and observe these children. So 5 take-home points. First of all, TSH and free T4 are generally best for assessing thyroid function in children. And in the case of hyperthyroidism, add a total T3. Second, levothyroxine is a pretty safe medication with side effects only if it's dosed in excess. So in subclinical and overt hypothyroidism, we err on the side of treatment. Third, children with decreased growth velocity should have thyroid studies as part of their evaluation. Fourth, rapid treatment of congenital hypothyroidism is really critical, especially if the TSH on newborn screen is greater than 40. You want to start treatment right away. If it's less than 40, you do have time to look at the results of repeat labs, but timely follow-up is critical. And finally, unless a thyroid nodule is less than 1 centimeter and has no suspicious features, all pediatric thyroid nodules require referral and fine